Let us explore the concept that always suture the wounds made in a pediatric cataract surgery, all the wounds, that is the main wound as well as the side ports. We should always suture these wounds with tenonylon. Let us explore this concept. Is it always necessary, or we can avoid suturing if we make the incisions in a different way? So this is the incision just behind the limbus on the sclera, and there is a conjunctival hood, and this is a 2.8 millimeter incision. The patient is a 7-year-old child, and this is a side port again made on the sclera with a conjunctival hood, and this is another side port again on the sclera just behind the limbus on the with a conjunctival hood. And now all the steps are as in other pediatric cataract surgery. Let us go through this. The anterior capsule is stained with trypan blue dye. This is a bit of adrenaline. The dye is washed out. Many surgeons will not use air bubble, that is up to them. And now the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. We have to use a sharp needle to make a cut on the anterior capsule. The tip of the iterator forceps doesn't work in these cases. And now again some visco, and now I am using the iterator forceps to do the rhexis. In such cases, the rhexis always tends to run to periphery, so we have to balance the outward movement and the inward pull, and these small jerky pulls help in keeping the track. So the rhexis was tending to go to periphery at 7 o'clock. I have been able to control it with small jerky pulls. Bit of hydrodissection, and now I go into the anterior chamber with the handpiece. No ultrasound is required, just irrigation and aspiration. Though it is in ultrasonic mode, and we may use 5% or 10% ultrasonic energy for faster removal of this lens matter. So most of the lens matter is removed. And now small speck of lens matter is remaining subincisionally. I have been removed the most of the cortex also by the handpiece, and now this is the soft lens matter, and with the help of a Simcoe cannula we can easily remove this. I could go through the right side port, so the wound is wide enough for introduction of a Simcoe. Even then, this side port will not require any suture. We will see that in the postoperative pictures. And now the anterior chamber and the capsular bag is filled up with visco. The bag is distended with visco, and then the main wound is enlarged to about 3 millimeter or 3.1 millimeter, because I am using a B cartridge and a sensor multipiece lens is going in the capsular bag. And here goes the lens. The cartridge is turned clockwise, the haptic comes out. As the haptic comes out and as the optic comes out, the cartridge is rotated anti-clockwise, and we deliver the lens in the anterior chamber. The leading haptic is in the bag. And now the trailing haptic is also placed in the bag. And now we dial the lens in such a way that we can go through the side ports and do vitrectorhexis. Okay, on-site port was not in the bag, it has been dialed in the bag. And now I have to use these side ports for vitrectorhexis. This is confirmation that the lens is under the anterior capsular rim with the help of a Sinskey hook. And now the anterior chamber, this little bit of lavage by the 23G Simcoe, and now we are going to do vitrectorhexis, means we are going to do posterior capsulotomy by the vitrectomy cutter. So, vitrectorhexis is maybe a misnomer, but it explains that we are making an opening in the posterior capsule with the help of a vitrectomy cutter. So, I go behind the lens and start cutting and aspiration. Irrigation is from above the lens, and the cut rate is 3000, flow rate is 30, and vacuum is 300 or 200. So, cut rate is 300, vacuum is 200, and flow rate is 30 to 35. Irrigation is from above the lens and cutting and aspiration behind the lens on the posterior capsule. And we make a nice opening. These cuts make small, very minute rhexis, and it does not extend. So, I am just checking if the wound will be stable without suture, and I find that the antechamber remains formed. So, I inject an air bubble to keep the antechamber formed nicely, and then this is moxifloxacin, and then I hydrate the side ports. The main wound has not been hydrated, still it will be nicely sealed. You will see that shortly in the postoperative pictures. The side ports are hydrated, and these wounds are very nicely sealed, and it is on the sclera, and suture is not required. I have done in this way many cases, and suture is not required if you make the incisions like this. The advantage is we do not have to, if we want to remove the sutures, we do not have to subject the patient, the child, under GA again. And now I am forming the antechamber and check if the main wound is leaking or not, and I find that it is not leaking. So, scleral wounds just behind the limbus are very strong wounds, and they need not suture. See the post-op pictures. This one without holding the lids, and this one is showing the main incision, and this one is showing the left side port. This one is showing the main incision and the right side port, and this one is showing all the wounds absolutely sealed. The antechamber is quiet, intraocular pressure is normal, patient is having very good vision. Thank you very much for your attention. Hope this video will challenge the concept that all the wounds made in a pediatric cataract surgery need to be sutured. If we fashion the wounds on the sclera with conjunctival hooding, then we need not suture the wounds.